And now this flexor digitorum longus has a trigger point right up here on the medial portion of the lower leg, and refers down into this area a little bit more laterally than you might usually feel the tenderness from plantar fasciitis. Tibialis posterior is usually palpated, the trigger point's usually palpated a little higher than this diagram will show, and will refer primarily to the Achilles tendon, but also secondarily to the insula and arch area. Now the quadratus plantae, which is the muscle just below the plantar fascia. The trigger point is right here, frequently just where the plantar fascia would be tender, and gives you heel pain rather than distinctly pain at the site of the trigger point. More often it's referred pain to the heel. Then you have all these intrinsic toe flexors. The abductor, this abductor digiti minimi, which is right along here in the lateral foot. You can have the abductor hallucis, which is this muscle right here that abducts the big toe, and the flexor digitorum brevis, which is this muscle here with flexor tendons that go to each toe and will come up into the attach at the calcaneus, and will frequently give you irritations here if the muscles are tight, which is very similar to where the plantar fascia will give you irritation when it is when it has micro tears. So these may all contribute to the pain that a patient has from myofascial trigger points, but not to actual plantar fasciitis. The treatment, if you have it, a patient comes in with this diagnosis and you haven't ruled out either one. You obviously want to reduce activity somewhat. You want to get a dorsiflexion splint so that you keep the plantar fascia on a slight, very slight stretch, especially at night when the patient is sleeping and might be tempted to be pointing their toes, and thus allowing the plantar fascia to shorten. The trigger point inactivation, once you've discovered these trigger points, using the laser, and I think especially if you're looking at the intrinsic muscles in the foot, you should be using the laser cone that turns the ML830 into a single beam, low power laser for those intrinsic muscles. And you want to control excessive pronation. If you think the patient does have either a small amount or a significant amount of plantar fascia, you have to add a small arch support during the treatment so that the patient is not constantly irritating that plantar fascia. And once the arch pain and heel pain is gone, then you need to evaluate whether or not the patient needs that arch support long term with the shoe inserts that will correct pronation. Most people with excessive pronation have flat arches that don't move and therefore would not need an arch support. And this is the reason most of the custom made orthotics end up in the closet. Okay, are there any questions about plantar fasciitis that you'd like to ask about? Put them in the chat box. Otherwise, we'll wait until the end to have some questions about both. Okay, we're going to talk now about tennis elbow, which is formerly known as lateral epicondylitis, which is usually the inflammation of the brachioradialis tendon attachment at the lateral epicondyle of the olecranon. If it's allowed to become severe and chronic, it may need injection with cortisone and or surgical debridement. You should try to avoid these interventions as they will often weaken the tendons and make the problem very much long-term and chronic. The primary cause of lateral epicondylitis is the ulnar deviation or dropping of the wrist. If you try to drop your wrist towards the ulnar side, you can see that this will put a strain on the brachioradialis muscle and long-term will result in activating trigger points, tightness in the muscle, and pain at the tendon attachment at the elbow. And this can happen in sports. That's the reason that good tennis players will frequently use two hands for the backhand to avoid dropping the wrist. Diplomats and others who are in a receiving line shaking hands will tend to drop their wrist when they do that, which is why you'll often see someone who does this frequently using two hands to shake another person's one hand. Or repetitive stress injuries, such as being on the assembly line and doing the same turning of a ratchet or a wrench constantly all day long, or using a computer mouse all day long. Again, you can imagine how you could get significant ulnar deviation of the wrist using a mouse. Another cause is if you have too tight a grip on too small an item, such as a pen, tennis racket. A good player will make sure that their racket size is large enough so that they don't grip the racket very tightly. They have to grip it just enough so that it doesn't fall out of their hands, but not too tight that it gives them an injury to the forearm muscle. Same thing with a tool on the assembly line or a golf club shaft. These are all kinds of things that people do that may cause injury and can cause the lateral epicondylitis symptoms. It can appear suddenly or have a slow, insidious onset. It could be either one. If we have myofascial pain, the muscles involved, we'll get to that in a minute, but it almost always begins with activating trigger points. That's one of the things that you see. Patients will always tell you that their forearm started bothering them first before the elbow did. The muscles that may be involved and should always be palpated to look for trigger points include the brachioradialis, the extensor digitorum, particularly the one that moves the third finger, the extensor carpi radialis, the extensor carpi ulnaris, the brachialis muscle, biceps, triceps, infraspinatus, supraspinatus, anterior upper trapezius, pectoralis major, and minor. These muscles here, the infraspinatus, supraspinatus, upper trap, pec major, and minor, all may refer into this area and set the stage for development of the problem, even if those other causes are not specifically present. These others are, the initial ones are the ones that are usually irritated by the particular activity and may in fact be the underlying cause of the lateral epicondylitis. Now here are some pictures of the muscles involved. The brachioradialis, you see this muscle right here. It refers down to the area between the thumb and index finger, but it also refers right to the area where a patient has pain at the epicondyle, and one needs to palpate this epicondyle very carefully to see where in fact the pain is, because if it's higher, it's most likely the brachioradialis. If it's lower, it may be one of the other forearm muscles. So it's important to know where the the actual pain is by rubbing your finger very gingerly over that painful area, and the patient can localize it for you very precisely. The extensor digitorum, particularly of the third finger, will give you pain right here and often is associated with the brachioradialis trigger point. They're almost always activated together. Then we have the extensor carpi ulnaris that runs along the ulnar side here, and will give you, I should say, gets irritated when you have a lot of ulnar deviation, and you find the trigger point here. Most of the referrals to the wrist, but you occasionally, if the muscle is very tight, you'll get some mild tendonitis type symptoms right up here. The extensor carpi radialis, as you can see, refers pretty much right to the same area of concern, as well as down in the thumb, is very similar to the brachioradialis in terms of its patterns of pain. The brachialis muscle found right here on the lower part of the humerus and goes across the elbow, normally refers down to the thumb primarily, but will give you some tendon irritation down right at the angle of the elbow right here, and is often associated with pain on the lateral epicondyle, which is over here. The biceps, same problem, same situation. It not only refers up to distinguish it from the brachialis, but it refers down to that same area, and will often set up this problem right in here. Excuse me, it should say right up in this area here. Patients perceive this pain often as extending throughout their upper arm. The triceps, as you can see here, there are, the trigger point 1 is a medial epicondyle problem. Trigger points 3 and 4, 1 and 2 are medial, 3 and 4 are more lateral. This is the lateral epicondyle for trigger point 4 on the distal part of the triceps, and you may in fact get some of the same referral pattern from trigger point 3. The infraspinatus, again, here's where the trigger points usually are, and the pain is usually referred either into the shoulder or down the arm all the way here. This usually sets up some of the dysfunction, which may then make the lower arm or the forearm dysfunctional. Supraspinatus, basically the same thing, just a little slightly